Okay, welcome everyone. Thank you for coming. We'll get started. I want to introduce myself very briefly. I'm Megan Daugherty. I'm the Administrative Director of the Center for Global Health here at Penn. If you haven't met me, you're interested in any global health programs, whether you're with an MPH, MD, or anywhere else at Penn, feel free to come meet with me. We have a website. You can find my email address pretty easily. I just want to let you know, first of all, the food is coming in sometime around now, so it'll hopefully not be too disruptive, and then you're welcome to go up and help yourselves to it as we go along. But other than that, we are going to start. I'll give a very brief introduction of Dr. Owusu-Dabo. He will then actually talk about himself a little bit and also his center and what it does, and have a little bit of time for some Q&A if you have anything about that, and then we'll get into the talk. So I'm very thrilled and honored to have Dr. Owusu-Dabo here. He is a mentor to me. He was actually my preceptor for my MPH capstone. He is also now a colleague and a dear friend. So I will not say too much more about him and let him tell you about himself. Thank you, Ellis.
Thank you.
And this is going to be recorded, and he asked that you repeat the question.
Okay. Well, good morning. Is it? Still morning? Okay, great. Good morning. It's great to be here again. About 5-6 years ago, we started this collaboration. Then Megan was not in med school. Met with Professor Beth and Sarah and a couple of others. Met with David. So I have great friends here. And our first president, Kwame Nkrumah, also schooled here. So Ghana and University of Pennsylvania share a lot in common. And I've enjoyed every bit of the collaboration since the last 5-6 years. So Megan feeds me with a certain addiction, and it's coffee pebbles. Espresso, chalk espresso beans. I love it. And I have people come into my office ever so often to come grab it. These are so beautiful. Where are you getting these from? And I'm like, well, there's only one source. And guess where it is from? Pennsylvania. Okay. So, just a little bit about myself. I got into research, let's say 15-16 years ago. And I joined the Kwame Nkrumah University of Science and Technology. I was driven into the field of tuberculosis and then lately into non-communicable diseases. But tuberculosis, because people were not interested in TB, and it didn't have a voice. It's pretty much a disease of the poor, as you're aware, and there were no resources, particularly when it comes to TB in children. So I got interested, and I decided to answer some of the few questions that were begging for answers. But even before then, I joined the School of Public Health. Then it was the Department of Community Health, and started doing the usual, being a faculty, teaching and interacting with students and so on and so forth. At the time, I was coordinating one of the biggest TB studies under the auspices of the Kumasi Center for Collaborative Research in Tropical Medicine, which is based at the Kwame Nkrumah University of Science and Technology in Kumasi. And it was such a big study. I had to travel throughout the 10 regions of Ghana to set all of this up. And then I was driven to see, the poor people across the countryside and so on and so forth. Little did I realize that eventually I was going to join the Kumasi Center for Collaborative Research, first as Deputy Director in 2009-10, and then later in 2012 I became the Director of the institution. So the Kumasi Center of Collaborative Research originally was set up as a bilateral agreement between Ghana and Germany. And Germany was represented by the Bernard Nocht Institute for Tropical Medicine, and Ghana was represented by the Kwame Nkrumah University of Science and Technology. And the exact department or faculty was the School of Medical Sciences based in the university. So at the time, the School of Medical Sciences, as it were, midwifed, the birth of the Kumasi Center for Collaborative Research in Tropicana Medicine. And then eventually it became, then we were not into a collegiate system, now we're into a collegiate system. In the university we have 6 colleges, and at the College of Health Sciences, it's now the official research arm of the College of Health Sciences. There are as many as 6 groups in the Kumasi Center for Collaborative Research. My group focuses on non-communicable disease and tuberculosis precisely. And then there are childhood fevers group, there's a Bruley ulcer group, there's the sickle cell disease in collaboration with the University of Pittsburgh. Professor Solomon Oforiakwa is the leader. And then we have the onchocerciasis groups. We're very strong in neglected tropical diseases. So there's the onchocerciasis group and there's a Bruley ulcer group as well. And I'll show you pictures in a bit. So all of these groups, focus obviously on their key research questions in relation to the disease entity that they are interested in. In the last 15 years, as I indicated, we have focused on TB, and we've looked at drug resistance. We've looked at the role that is played by cytokines, in particular microRNAs. We've looked at the whole inflammatory area of inflammatory biomarkers. We've looked at a lot into the genetic susceptibility factors of TB. And lately, in the last 5 years or 6, I have looked critically into non-communicable diseases, and in particular type 2 diabetes. And the reason for that, I will tell you this late afternoon when I present the talk on the dual burden of disease in Africa. So to start a collaboration with us at the KCCR, we, as I said, it was between Ghana and Germany, but now it's outgrown beyond, Ghana and Germany. I mean, we have American institutions, we have institutions from the United Kingdom, from South America, from elsewhere, all of which do a lot of research. As many as about 9 at the last count, 9 institutions from the United States, doing a lot of research in the Kumasi Center for Collaborative Research. KNUSC, which is the mother university, is a very big one. I don't know the population of students here, but we have 44,000 at KNUSC, and it's USEC and others. Miriam, you saw such a big area. I don't know about the total, but what's the total population? 20,000, so half of that. So it's nice, I have to say, to be there. So those of you who haven't been to Sub-Saharan Africa, let it be your first stop, Kumasi. So come to Kumasi, let it be your first stop, and we will treat you to all the goodies. Pito will get you drunk. Nearly will. Okay. And of course, there are the other goodies as well. Beautiful environment to do research, beautiful people, hospitable extremely. And I'm hopeful that those of you who are considering doing your exchanges and partnerships in Africa, you'd consider Ghana. Okay. So I think that was a great time to break.
Yeah, we're sorry they couldn't make it before 11:30.
That's all right.
It would be better to break
here.
Are you almost for making?
Almost. So then, to probably if you, as people go for whatever, they can ask questions on my institution and what we do and so on. If there are any other further questions, I'll take them whilst you grab something to eat, and then I'll proceed. I'll proceed with the main talk. So any questions? I'll take any questions on anything in relation to Ghana. It doesn't have to be my institution. You're going to be hearing the talk in a bit, but just so that. So,
Dr. Owusu-Dabo, what are the top health burdens these days, disease burdens in Ghana?
So you know that traditionally we've had issues with communicable diseases. So Malaria is still number one, although the global burden indicates that it's going down, and I will say a bit about it this evening. But following malaria, we have upper respiratory tract infections, skin diseases. Road traffic accidents is a big one. We have issues in relation to maternal deaths, childhood diseases. They are big. But in addition to that, I'll be telling you this evening that type 2 diabetes, hypertension, and cardiovascular diseases are inching. In a place like Kumasi, where we're based, cardiovascular diseases is the number one leading cause of mortality at the teaching hospital.
Wow.
Yeah. And type 2 diabetes is now, when I was in medical school, not quite long ago, I mean, we wouldn't talk about diabetes, as a health problem for Ghana. But at the moment, it's type 2 diabetes is somewhere around 10, 9, 10th position, occupy 10th position or 9th position, depending on where you are. In Kumasi, certainly it's number 9. So it's big. In addition to our traditional problems, and of course, we also have the neglected tropical diseases. So onchocerciasis, Buruli ulcer, schistosomiasis. These are all issues that bedevil the country. There have been, I have to say, and I'll say this again this evening, there have been improvements in some of the areas, particularly in child survival, thanks to the many interventions through the MDGs and now the SDGs. There have been substantial improvements in some of these things, but there's still a long way to go in terms of reducing the burden of diseases. Any more questions?
I have one more question.
Yes, maybe.
Ebola. What happens with that in Ghana? How is the response in Ghana? And what is the current?
I was so sad that the University of Pennsylvania did not come to Ghana. Was it 2 years ago?
Yeah.
Yeah, but of course it wasn't your fault. It was the State Department that issued the alert? CDC. Okay, so yeah. Okay, so because of that, you know that you did not visit us because of Ebola, which is, but I can understand. This food is good. You have to survive to eat this food. Okay, so Ghana did not register a case. We did not have a single case of Ebola, but we were on the high alert. Why that did not happen, I, as an epidemiologist, cannot explain. Because we were at the center of coordination of all the activities. And guess what? All the flights that had to go to all of these countries had to pass through Ghana. So while we did not have a case, it's really beyond comprehension, because we were actually the topmost country at risk of Ebola, and in West Africa. Nigeria, went past us. They recorded a case, and of course subsequently had all the issues. So I cannot explain why. We've all, we've talked about this. We've discussed it in many ways. We've tried to, but so to our east, to the eastern side, we had Nigeria. To the northern side of Ghana, we had Burkina Faso, Mali. To the western side, we had Liberia, La Côte d'Ivoire, Guinea, Senegal, of course, and Sierra Leone. And we stood at the center. And of course, the south is the Gulf of Guinea, the Atlantic, so I cannot tell you whether there were cases in the Atlantic. Okay, on a more serious note, I think we got the message early. The issues with Ebola had to do, as you have read in many, from many sources, had to do with weak health systems in West Africa. It had to do with myths as far as the understanding of the pathophysiology and disease transmission processes are concerned. It also had to do with the ill preparedness and lack of communication in terms of how perceptions were dealt with, and reporting and so on and so forth were dealt with. So the containment issues took a very long time in terms of logistics arrangements and so on and so forth. There were also issues with power brokers. So for example, America would be interested in Liberia. The Great Britain, for example, would be interested in Sierra Leone. France would be interested in Sierra Leone, Senegal, and so on and so forth. So there was lack of coordination. In the middle of all of this was WHO, and then there were other Médecins Sans Frontières and other people, you know, MSF and co, who were they also had their own interests. These were the issues. So the improper coordination and the different interests, it took a long time, relatively. I mean, if you have to compare with the number of cases that had died before we took action, before mobilization and understanding of a concerted effort to gain momentum in dealing with or containing the situation took place. And this, to my mind, was one of the biggest contributory factor in terms of the mortality. So sadly, we lost so many people. At the last check, I think it was nearly 30,000 cases. And we know the strain of the virus. There's so many unanswered questions regarding Ebola. The first case that was reported was purported to have been from game. We're still not sure. It was traced to fruit bats. It was also traced to one of the delicacies in West Africa, grass cutter. So it's still shrouded in myths. And what fueled all of this was the lack of understanding of, so for example, some of the cultural practices that were being perpetuated in these countries also fueled the transmission of the disease and obviously led to the many deaths that were recorded. So not quite over yet. You're aware that in the last 3 months or so, a case was reported of a man so this was the first alert of potential sexual transmission of Ebola. We are aware that the virus can persist in virtually every body fluid. What we do not know is whether the transmission does occur, in fact, in all of these body fluids. And there are several studies in New England Journal of Medicine. There are several studies that have been published. There's the so-called post-Ebola syndrome, which is a very big issue. I mean, people losing their memory and losing their hair and losing all sorts of things, lack of coordination. And there's a whole issues that have to deal with the acceptance of post-Ebola patients. So all these are issues that are being grappled with in all these countries that have been, the amazing thing is that Nigeria took a center stage and managed to contain the disease, and therefore the mortality, the cases of people who died from Nigeria were much, much lower than anticipated. I mean, if Nigeria had gone down the drain, we would have been in deep, deep trouble. As you're aware, their population is close to 200 million, and that would have been immense. Okay, so this will be the outline of my presentation. First, I'll look at the TB burden in Ghana, globally first, and of course Ghana. And then I'll look at the transmission, a bit about the pathophysiology and disease transmission. Then I'll look at the diagnosis and management and some of the challenges we have in Ghana. I will then continue to look at the current drug resistance survey that is ongoing in Ghana, to which I'll present a couple of findings to you. And what we're doing by way of social media. And finally, I'll give you a take-home message, and if you have any questions, I'll take them. So, I'm sure, let me get this one right here. So TB still, this is over 200 years ago, but still causes a lot of problems. Causes as many as 2 million deaths annually. And in 1994, thereabout, the World Health Organization introduced a concept which is known as the direct observation treatment short course, as one of the ways of trying to control the disease. And this program by the World Health Organization has two components, which is the intensive phase and the continuation phase. So the intensive phase, depending on which country and or continent or WHO region where you belong, would have different classes of first-line medication that was used. In my country, the first 2 months, the intensive phase, we used to have streptomycin as one of the components. We no longer do because we had a single mono resistance of approximately 9% to streptomycin, and therefore it was taken out of the list of first-line treatment. And then, of course, the second phase, which is the 4 months, so a total of 6 months. For the second phase, which is a continuation phase, we have 4 months of isoniazid, rifampicin, and ethambutol. So overall, I have to say that the global picture appears to have made substantial declines in terms of TB. But from the estimated global TB incidence, you'll see that, okay, so there is Ghana, for those of you who are still imagining where Ghana is, west of Africa, still in the west, it's still sitting there. Okay, may change. Okay, so our reported incidence there is somewhere, this was by WHO estimation. A lot of this has to do with statistical modeling, so the picture might be, we believe, slightly higher than that, and I'll give you figures to show that from the last prevalence study that was conducted. This I decided to show you because of the dual burden of TB and HIV, and this also has to look at the estimated percentage of adults who had HIV. I'm sorry that this is a long time ago, but I can say to you that the present prevalence for Ghana is under 1%. So our point prevalence of HIV/AIDS is 0.8%, so it's still under 1%. But as you probably know, the south of Africa has the highest prevalence of HIV/AIDS. So I'll give you some case presentations. So this is a 66-year-old male with a cough of more than 2 weeks, acknowledges chest pain, weight loss, self-treatment, and this happens quite often, including antibiotics use, contributing to the menace of the antimicrobial resistance that we have globally, unfortunately. And so this man was on self-treatment and went to the pharmacy, denies TB history, and when we took the sputum for ZN, it was 2 pluses. So, and we realized that the morning we indicated that he was multi-drug resistance. He was positive for the M tuberculosis complex, and you hear such stories often and often. And until we decided to do what we call the prevalence study, a lot of these cases would have been missed in the community. So we think that communities' active cases should be something that we should be looking at. We haven't as yet looked at. I mean, I think that is obviously financially cumbersome, but one has to think about it. The second case is a 60-year-old man with a cough of more than 2 weeks, acknowledges chest pain, weight loss, self-treatment, denies TB history again. This person had MTB complex positive and was positive for the midget and the gene expect, which we do routinely at the center. The third case is a 40-year-old man, denies cough and denies TB history, was 3 pluses on Zeal-Nielsen, and of course the fluorescent microscopy was also 3 pluses, was positive for midget spot, and gene expect was also positive. And finally, my fourth case is a 52-year-old male. By the way, the risk of TB is twice as high in males as compared with females. And in this case, a 52-year-old male denies cough and was positive for Zeal-Nielsen, was scanty for fluorescent microscopy, And the morning, as you know, was 2 pluses and 1 plus for fluorescent microscopy. These are the sort of things. So you may not have a case presenting with cough, but as you would see from these chest X-ray, which was revealed from our, and same for those. Those are the ones, you can see almost a miliary presentation. So is it Mycobacterium tuberculosis or not? And is it non-tuberculosis mycobacterium? Is it multi-drug resistance TB? These are questions that if you're a practitioner, you keep asking yourselves often and often. And first, you have to get the diagnosis, and second, you have to decide what are we dealing with here. So I have to announce that last year the National Prevalence Survey was conducted for TB to estimate the burden of TB, and so the drug resistance survey is running on the heels of the National Prevalence Study. So again, you hear this over and over again. 9.6 million people fell ill with TB in 2014, and 1.5 to 2 million die, and of course, 1.2 million people living with HIV develop TB. So the association rate, depending on where you are between TB and HIV/AIDS, can range from anything between 10 and 40%. So in Ghana, our studies have demonstrated an association rate of around 14%. Okay, so I decided to show you case notification in Ghana. So the red shows you the highest case notification. This is the Upper East region. So Ghana has 10 political regions. This is the Upper East region. This is the Volta region. And here you have the eastern part of the eastern region. You have the Greater Accra region, you have the western, and then the central region. So these have the highest case notification, the Upper West, the Upper East, the Volta, the Greater Accra region, which is the national capital. The central region has quite some very high case notification, and of course the western region. It has to be said, and I'm sure that you know the correlation between poverty and TB. Similarly, it's reflected here. So but it's interesting because the Upper West region, the Upper East region, the northern region, these are the poorest regions in Ghana, as well as the part of the northern part of Volta, and then of course also the central region. This is one of the poorest regions in Ghana. So this is case notification per 100,000 of the population. And on the right, you see the district notifications. This is the regional notification, and this is the district notification. So a little bit about disease transmission and pathophysiology. Ordinarily, if you are in Africa, you may have been exposed to the Mycobacterium tuberculosis complex. Here, I assume that you receive your immunization, same as we do in Ghana with BCG. BCG can only protect you up to age 9. You don't get BCG? No more? Okay. But the interferon, you get the interferon gold? You don't get that one? No? Okay. What about, I heard about, nothing. Oh, I heard about focal, in migrant populations, focal interventions. I read about something like this in the States. Okay, maybe it's no longer there. But anyway, so we get a BCG immunization at birth. It's given at birth. It has to be given first 2 weeks of life, and you don't get any boosters. You're protected until about age of 9. So says the literature, and the evidence is there. Beyond age 9, you pretty much are on your own, and many people would be exposed. So Ghana is considered one of the medium burden disease countries. So when somebody, and it's transmitted essentially through, the air, droplet nuclei, so coughing, sneezing, deep kissing, it is said, and it's not been recorded, so many of them, but it is said, shouting, and of course when you have a cavitatory patient who is coughing directly in front of you, then of course you have to be very careful. When these droplets get into your nasal cavity, they get obviously into the lungs, and the Mycobacterium laden droplet then will be attacked initially by the alveolar macrophages. It is considered one of the delayed hypersensitivity type reaction, delayed type 4. So you have Th1 cells that will migrate to the cells, will and try to fight, capture the mycobacterium. In that process, they attract other cells. The dying cells then forms this caseous substance. This caseous substance then will be cuffed up, and when they're cuffed up, they break these capillary cells in the alveolar, and then they form the cavities, the typical cavities that you see usually in the upper lobes of the patients. So this is a typical, many people escape. That means they get infected, but they don't get the disease. And we know that 1 in 10 will end up with the disease of those who get infected. 10% get a disease. And there's so many reasons why people get the disease, such as poverty, such as malnutrition, use of certain medications, including corticosteroids, and of course, suppression of one's immune status. You can have a reactivation of the disease or the infection, and therefore leading to disease, or when people are on cancer therapy and of course on transplants and so on and so forth, they get an immune system depressed or suppressed, and then of course you can have a reawakening of the dead, as it were, so to speak, mycobacterium complex that is sleeping in your lung, and then it gets reactivated. So that's a little bit on the pathophysiology. Typical symptoms would include cough. Absence of cough, by the way, does not mean that the person cannot have TB, has to be said. Unintentional weight loss has been extensively documented. Night sweats, fatigue, fever, constant fever, chills, and of course loss of appetite, which is pretty much for everything. How do we diagnose TB? So there are several, and several are also in development, because the typical lag phase takes quite some time with, for example, cultures. So first step, you must have in Ghana, you must have a cough of 2 weeks. Okay, so if you cough, it's mandatory that if you cough for 2 weeks or more, you must see a physician, or that you have to be examined for TB. And so the chest x-rays are done. Of course, the physician or clinician will listen to your lungs, and of course will have a suspicion. So you're sent to the laboratory, and of course when you get there, you can have the sputum test, which includes microscopy, so the staining and the ZN or any of the other staining techniques, including fluorescent microscopy. And then, of course, you can also have cultures. This is typically done in research laboratories like ours. You don't want to wait for 10 weeks to read, up to 10 weeks to read a culture result before you treat a patient. So normally we rely on microscopy, and this is what is fully deployed across the country. So, and of course, we know the sensitivity of microscopy ranges anything between 20 and 40%. So the sensitivity and especially when you have overworked staff and faulty microscopes, then of course it worsens the sensitivity and so on and so forth. So it's important that one considers other techniques, and these includes molecular-based techniques through DNA amplification techniques. David and I talked about some other amplification techniques, thermal amplification, and how to go about some of those improvements in the diagnosis of TB. Then, of course, there are those that are related to the immune factors, which have been developed and deployed also extensively. A lot of it has to do with suspicion of early case diagnosis of TB, not the subject of this discussion. So I told you about DOTS and what we do. I've mentioned about the medications that are being used. The challenges we have in Ghana essentially have to do with low case detection. So at the last check, our case detection is still under 40%, which is not the best. And the insensitive tests with ZN, of course, the late detection, late reporting, non-specific tests, I told you about the overworked staff and so on. We don't have biosafety laboratories. There are not more than 4 biosafety laboratories in Ghana. So my research institution is one of the other, one of 4 that, has a biosafety. And even at a teaching hospital, it's just only recently had a biosafety laboratory for diagnosing TB. So there were issues because of the lack of diagnosis or proper diagnosis, the documentation and inconsistencies in literature. WHO had to be modeling the figures and telling us what the numbers were in terms of incidence and our prevalence. So questions about our incidence, sometimes it's The initial prevalence before our national TB survey was 281 per 100,000. Actually, the estimates after the survey indicated that Ghana was quite high in terms of case notification or prevalence, which is 376 currently, as would be seen from the WHO website. So it was important to look at the issue of drug resistance survey. First, to consider the burden, and second, to take action. Two, as I indicated, drug resistance, so poor clinical care, lack of adherence, defaulting by patients, and so on and so forth. It's very difficult when patients have to take medication for 6 months, literally every day for 6 months. They just think, well, it's enough after 2 weeks, especially when the cough stops. And therefore that can lead or contribute to the antimicrobial resistance problem that we do have. And so it's important to document this. So we had done earlier studies, which I'll tell you about. And of course, non-adherence to treatment, prescription of correct treatment regimens. These are all problems that we face in the country. So we decided to document as early as 2005 or so. We started in 2001, and we reported in 2006 on multi-drug resistance of 2.2% in Ghana from several regions. And although it was not nationally representative, it was quite a large cohort of TB patients. And then, of course, others also reported something around 3% from other studies involving Newman and co. Margaret. There were other studies from Atoforsen and co. From the Ghana Medical Journal in 2010. They reported under 2% of drug resistance TB in Ghana. So the question was, what was the real problem? The big shortfall with all these studies was that they were focal. They were in certain populations that were not nationally representative. So it was important to look at drug resistance survey with the national representative data. And if you check from the Ghana website today, you'd realize that Ghana doesn't have data on drug resistance survey. So the WHO got interested, and I was contacted that we had to put a team together to conduct a national anti-tuberculosis drug resistance survey for Ghana for the first time. So the key players are the National Tuberculosis Control Program, which is the supervisor. So we're basically implementing, and they are supervising us. The Chest Clinic, which is also based in Accra. The National Reference Laboratory, which is acting as a supra-reference laboratory based in Boston. This is actually WHO's partner working as a supra-reference laboratory based in Boston and close to Hamburg in Germany. And of course, my team based in KCCR is implementing the study. So what is this study and what are the inclusion and exclusion criteria? You should be able to produce sputa, and you must be smear positive. And of course, you must not have taken anti-TB drugs for more than 7 days for the current diagnosis, and you must be willing to donate 10 mils of your blood for other things, which we do, including immune factors, something that I'm interested in. So it's not just the drug resistance, but also engage in a conversation for a maximum of 30 minutes. You know, we take other things, and you must be 18 years and above. I have somebody else who is looking at children with TB. It's a neglected area, and one of my PhD students is looking at that. So the design is a cross-sectional. It's a two-stage cluster randomized technique. So we sampled on the basis of the health centers, the frame, the sampling frame is the health centers, and we took a two-stage randomized design, selected from the health centers, and then, of course, we had all these microscopy or diagnostic centers from the health centers included. Eventually, we had 32 in total. We sought for ethical approval from the Committee for Human Research Publications and Ethics based in the Kwame Nkrumah University of Science and Technology. And of course, we linked up with all the other partners who are involved in this study. This chart shows you the general workflow of what we're doing. And so essentially, the patient produces the sputum on the spot, and then there's a second sputum. So it's all barcoded and it's sent. You answer the questions. All of this is received and sorted at KCCR, And this bit is all that I'm going to be telling you about on how we use social media to promote this whole action. It was such, when we started considering, I mean, this is a country, it's nothing like what you see have here. Okay, transportation is difficult. How do we get SPUTA to this coordinating center? We have 33 centers across the country of about 30 million people. The not reliable transport network. We do have private road transport, network, some of which go to the very hinterlands, others do not. So how do you get all of this done and so on and so on? We came up with quite, not ingenious, I think, but just not just trying to replicate what others have done, really. Okay, so sample needs to be transported and tracked. So once the patient produces and all of that, we have the questionnaire barcoded, the questionnaire is barcoded, sample is barcoded, both of them, and the completed questionnaire is all sent to KCCR. We receive it, we sort it out, a laboratory component, starts. And of course, the laboratory people would do their, so first here there's a data entry, and then here the data entry instrument is also entered at KCCR. The laboratory people will also feed theirs real time into a server, which is all synchronized and then reported to the national TB program and of course the WHO. So this is how the workflow looks like. But before we did that, we had to sign MOUs, with the Ghana Private Road Transport Union. This is one of the private road transport unions that go to nearly everywhere in Ghana. So we had to do something. And the idea was, hey guys, this is a national thing. So all of you get on board and so on and so forth. They do charge us a token for transporting the sealed samples, well stored, packaged, because these are contagious potentially. So, and of course, one of the other private ones is the OA transport. We have courier services, and of course, in person, some of them will bring it directly to us. And this was letters that we sent, request to engage your transport services, signed by yours truly, my signature right down there. So, how did we track the samples? WhatsApp. So we created a group of all the members participating institutions. So we had 2 representatives of each institution, and we created a platform. And what did they have to do? They had to tell us. So of course these were the program manager was involved, the TB program assistant manager was the laboratory focal person, principal investigator, KCCR coordinator, receptionist, technician, national reference laboratory representative, and so on and so forth. And the group administrator was coming from KCCR. So they had to tell us, so they had to notify us when a sample has been sent, and then we send feedback. So part of the things that they had to, and this is a typical, so they have to tell us, of course, the name, what time the driver is leaving, which site, the car number. They take pictures of car numbers, what time they are leaving, and we can track. So we can have questions, should the vehicle break down on the road or something, we can track and say, oh, this one is going beyond the expected time of arrival. So here you have samples dispatched from Hawaii is in the Volta region. The driver name is Emmanuel Belkon. Telephone number of the driver has been provided here. Dispatch time is 20 hours. It will reach at 11 a.m. 2 samples, Raura and Hawaii. So these are from Volta region. And then you have car numbers. You have this person sample from Dunkwao. Dunkwao is from the central region. The car number is provided. Contact person is this, and so on and so forth. So we had several of these, to help us to be notified, and also for us to be able to notify them back when we receive. So notifications included date and time of dispatch, driver's name, car numbers I've indicated, estimated time of arrival, bus terminal, and so on and so forth, and signed dispatch forms that are accompanied. So these are some of the signed dispatch forms, car numbers that have been taken and shown here. It was awesome. I mean, it's still ongoing. To notice that we haven't lost a single sample, and that samples have arrived in good time. I'll tell you about the average time that samples have arrived in a bit. But these are. So tracking the samples again, so you have WhatsApp group platform, so somebody says, okay, thanks, and that's the name of this person. Minipa is my buddy, okay? And this is, Boku has delivered a sample of attention, Dr. Augustina. Some of you met Augustina when you were there in Kumasi. Sending facility gives notification, KCCR tracks samples, we call the driver, we call the station, and of course we track samples until they are received at KCCR. And when they come, we open them up. This is how they're packaged, okay, with sealed, whatever, the name, where it's coming from, the contact person, to KCCR contact person, and this is what you find, with labels and everything, and then we'll handle that. So when we receive these samples, then of course we take them through the following laboratory procedures. I'll make it snappy because it's not the focus of this. So the typical processes is that, we go through the microscopy, which I described earlier. The decontamination happens here, and of course we do liquid culture using the midget, the gene expert, and of course we have a repeat microscopy. Microscopies are done at the sites, but we do a repeat microscopy also at KCCR. And then of course the positive samples would be non-tuberculosis mycobacterium or mycobacterium tuberculosis complex. We go through the first line of resistance testing, which includes streptomycin, isoniazid, rifampicin, ethambutol, and there's a separate pack for pyrazinamide, which we take all of these through. So we report on mono and multi-drug resistance, which is resistance to either isoniazid and or rifampicin together. And of course, we have also those for the second line drug, kanamycin and capreomycin. We do that, and then of course we can report on XDR and susceptibles, and of course no results. So typical here, the slides are being labeled, sputum smears are done, slides hot plate. Of course, you do your staining with McLean blue or ZN. So this is a serpentine typical culture, which that the cell wall of the mycobacterium tuberculosis complex consists of mycolic acid and of course the wax D. So this together will form this serpentine structure, typically noted of. And of course, we do the liquid culture, typical liquid culture vials in there. The liquid culture is used for the growth detection and identification of MTB. It's very sensitive, requires at least 10 to 100 organisms to detect MTB. And of course, the culture allows drug sensitivity to first and second line drugs and other drug combinations to be performed. It has a high turnaround time as compared to other culture methods, particularly solid, which obviously can take up to 10 weeks, as I indicated earlier. It is disadvantaged by the long incubation time and high risk of contamination, and of course, some inconsistent results, when it has to do with performing LPA, for example, which has raised some of the issues. But yes, this is the BACTEC 960, which we have, and you have the immediate tube, middle block, and of course, I'm sure you've seen, just to show you some pictures from our BSL-3 laboratories. So these are the components of the BACTEC, and you have pictures here of what happens in there. I show you pictures of the flow chart of liquid culture that is performed. It's just to reiterate the point there. And of course, the earlier, sputum contamination processes which I indicated. The sample inoculation for the drug susceptibility testing is done. There are two different vials, as I indicated, the SIRE, and of course the PZA testing are all different depending on what you want to do. And of course, we have different techniques also for the second line tests. So I indicated that we do a reconfirmation of the ZN here, and of course, these are slides showing you some of the techniques that are done. And I've indicated the drug susceptibility testing. From a positive midget tube, day 0 positive, you incubate it at least for 1 more day, you run it, you follow the recommendation by WHO. These are all the preparation of dilutions and of course adding the growth supplements to perform the DST in these pictures. And of course, there's a typical positive, not very clearly demonstrated there, but you see a reflection there. These are steps that will show you whether it's susceptible or resistance. And I can tell you that as of, I checked this morning because I asked my postdoc to give us some feedback. We have an estimated sample size of 1,100 and something, 58, an estimated sample size. But as of today, we have recruited 493, including the pilot phase. We're at the 100 pilot phase. So for the actual study, we have 393, and we have 9 9 positive MDR cases, which works out to about 2.2% presently. But this is still only a third of the cases that we have recruited as yet. So, as at the time I was preparing, it was 310, but I checked this morning. This is a graph that shows you by region. So we have all the 10 regions. This was as at the 29th of July, so a long time ago. And these are the results from the different assays, the midget, microscopy, and of course, gene expert. And at the time, we had only one, but as I say, this morning we had 9 cases. So this compares the resistance with the sensitivity pattern for the first 159. It always lags a bit behind the DST, as you would imagine, because you have to wait for the culture results and so on and so forth. So the red obviously shows the sensitivity. A good thing is that it looks like our first-line drugs are working in Ghana, but with the report this morning, I'm hoping that it doesn't exceed the earlier reports that we had, which was between 2.2 and the global figure is around 2.1, right? I think it's about 2.1%. This is reported by Dai and Co. Okay, so our expected outcomes is that, we want to report on the first ever countrywide representative data on TB drug resistance survey and give us a prevalence of the same. And of course, we will also report on the types of resistance among the new and previously treated smear positives and enhance capacity towards effective surveillance of drug resistance. And of course, we'll be saying or reporting on directed therapies based on evidence. This will guide us in clinical practice, and then of course it will enhance collaborative efforts between us in the South and of course between North and South partners. Let me summarize by saying that Ghana's TB burden is still high. If you want to compare that with the rest of sub-Saharan Africa, it's probably relatively low. Same for HIV/AIDS, but we consider the numbers that have been reported by WHO in the last prevalence quite high. The current DRS is the first nationally representative data that will be churning out for WHO's and of course our own national planning. And we have found the use of social media, in this case WhatsApp, tremendously helpful in tracking the samples and of course yielding the results that we require. And as I say, the current proportion of those with reported drug resistance tuberculosis is still relatively low compared to other places. But given that the global figure is around 2.1, if we stick around 2.2, then we are not far from. These are the partners. And I'd like to say thank you. I'll leave you with a photograph of KCCR. My office is right there. And some pictures. Thank you very much for your attention. If there are any questions, I'll take them. Yes.
On your page with your memorandums of understanding, one item that I didn't see there was cell phone companies. Did you consider partnering with MTN or Vodafone or one of the national companies for their partnership?
It's a great idea. So your question is, you didn't see with the MOUs, the cell phone companies. No, they are not involved in this. They've been involved in other things that I've done, but I think it's a great idea. We didn't consider them as potentially helpful, particularly during the calls, so that we tell them, hey guys, this is important. Don't block our calls. At the drop, Ghana has a problem with dropping calls. How do you call it technically? I think there's a name for it. There's a call drops. It's quite high, and therefore perhaps but I don't know how we'll figure it out, but it's a great idea, which I would propose to the team to see whether we can factor that in. Still, hi, David.
That's a great topic.
Thank you.
So from like an epidemiological standpoint, given that it's around 2%, multi-drug resistant TB
Right.
right now, our current inability to diagnose it in the field very well, do you see this as a risk? And how worried are you about this?
I'm very worried. Your question, David, is that given from the epidemiological standpoint of view, given the current prevalence of 2%, how worried am I as an epidemiologist? And I think it's important to put this in context. there have been substantial efforts that have been made in the control of TB. For example, WHO, and there's a lot of evidence to suggest that DOTS does not work on its own. So we've gone on to DOTS Plus, enhanced DOTS, and community DOTS, and so on and so forth. We've looked at the enablers package, and so on and so forth. So I think we have to come up with creative, ideas of improving direct observation treatment short course, and also improving case detection. As yet, it's been passive. And Ghana, like many sub-Saharan African countries and developing countries, in Africa, are bedeviled with several health issues, and therefore sometimes I believe governments are not sure, health, people are not sure. How do we slice the cake, and which proportion should go where, and so on? I would, for example, be interested in active case search rather than passive case search. And there should be a way of doing this, and we have actually proposed this. The TB focal person, the national TB focal person, is a good friend of mine, which we've talked about some of these things, but they always talk about resources. Which is why we initiated a national prevalence study. I have to say that the cases I reported at the beginning were all actively sought out for. But to what extent? So it means that the burden is out there. And we have to look at, so for example, if you're looking for DSTs, tuberculin skin tests, and you want to perform, you can find it. And yet I think this is a simple, cheap, but effective way of telling whether somebody is at risk, and then of course subjecting the person to some prophylaxis. So we're still talking. It's all about resources, and how can we do this, roll it out, make sure that actively sustained, and so on and so forth. The lack of numbers of health workers to be able to go out into the villages and communities to be able to diagnose all these people. It's a dodgy area because of the general burden economically. But great idea. We have to do active, I think. Oh, we're taking the GPS. We'll do this, and I promise you, I'll show you I'll share with you some of the findings when it comes to clustering, and where potentially we can have some notifications of potential epidemics of drug resistance in the future when all of this is done. But these are early days yet, as I indicated. So it'll be interesting to find out, spatial epidemiologically, whether there are clusters, and what types are we dealing with, and what subtypes of strains are we dealing with, and so on and so forth. And those would come when we have a full complement of the data that we're dealing with. Please. Fantastic. Fantastic. Whereabouts in Tanzania? Oh, amazing. I've got friends in Arusha and in one other spot. Oh, great. I think it comes across, as you probably are aware, Ghana, at some point CNN reported Ghana was one of the countries with the fastest use of mobile phones, even in the rural areas. And those of you who've been in Ghana, some people who have 2-3 mobile phones and so on. So it comes across as a natural thing to do, because all of these coordinators, we didn't have to provide them with these phones. Nearly every phone is smart. And it just comes, across as a very simple tool, and it's great, I think. Yes?
Just wondering how you were coordinating across the country with medical centers. Are there particular medical centers or doctors in particular that the doctors have to be the ones to initiate the sampling and send it?
Okay, so every center that diagnoses TB has potentially a TB coordinator for the district. And all of these coordinators would potentially have a laboratory person they work with. So we took for every health center that diagnoses TB, not the doctor, but the TB focal person and the laboratory person, because these are potentially the two people who are likely to report or notify us of TB. So these two people are those that we put on the WhatsApp, and they have to, or they must, report. And it was great. The doctors, of course, are in the picture, in the background. And for all the training, we organized training for all of these centers, brought them on board. We had to explain each of the questionnaire, the tools that we're using, how to fill them, and so on and so forth, the reporting, how to send the messages to the transport people, and so on and so forth. It's been awesome how we've managed. It was very difficult. We had to do the training sessions on 2 occasions, and even with that, you still come up with some forms that are not completed, and so on and so forth. And you have to call the person up and say, hey, this form, so and so with this number comes up as missing on this. Would you kindly, and so it's an ongoing thing. You have to keep reminding people, and it's not easy. But that said, WhatsApp has been amazing. Yes, please.
Of the medical centers in, what's the percentage that have TB coordinators?
Every center, okay, so from the 10 regions, at the last check, I think it was we had over about 300, centers that diagnose TB. All these centers have TB coordinators. Every center has a TB coordinator. It's a must. Before you're designated as a TB diagnosing center, you must have a TB coordinator, nationally represented. Your name is in the books from the National TB Program that says that X person is responsible for so and so in X district in X region. And that's how it works. So all of those health centers have TB coordinators. Yeah. Okay. Yes, Megan?
You are based at the university and you're faculty there. Were you able to engage any of the trainees in school, public health, or med school in this whole?
Okay, thank you, Megan. So Nanaya Iwaboateng, whom some of you know, is my PhD student. She's working on childhood TB and has been roped into this. I have two other PhD students, and I have one master student, the laboratory technician, Rexford. I don't know how many of you met Rexford. He probably must have taken you to the BSL-3 laboratory. He's an MPhil student. So I engage some of those as students working, and this, by the way, is what we do. If you're a faculty and you want to start something with us in KNUST, as part of the collaboration, we must train students and develop their capacities in whether, grad students, so MPhil or MSc or whatever, and of course also PhD, depending on whether funding will allow it or not. Yeah. Okay, David?
One last question.
It doesn't have to be the last.
For me.
Yeah.
So do you know in terms of pediatric cases, is it drug resistance?
So at the moment, we haven't had a single case reported from certainly not from Nanaya, but it's early days yet. So David's question is, do I have any? Do I have an idea about the burden of drug resistance within the pediatric population? It's early days yet for the study that Nanaya is coordinating, because she's looking at children under 14 years of age with TB. And as you would know, it's a neglected area and it's difficult to diagnose. So our estimated sample size, I think, is in the range of 60 or so within the period. And we're hoping that we can report on something. But not getting something is also a report, so we'll stick with it.
Well, I would like to then thank you, Dr.
Thank you. Thank you.